So let me write some names down here. Jake, Brian, Dennis, Jonathan, Eric, Jay Krugman, Paul Frieda. So we have one person on the telephone who hasn't identified. Would you like to tell us who you are?
This is Sylvester, Mayor.
Hello, Sylvester.
Hello, everybody.
Hi, Sylvester.
So let me run down who I see on the call, and then we'll get going here. And I'll do a round robin. So I see Jake, Brian, Dennis, John Appler, Eric Bookbinder, Jay Krugman, Paul Frieda, Sylvester. Did I miss anybody? Okay. So since everybody has been on this call at least once before, I'm just going to go down the list and see who's got something to talk about today, at least to begin with. Jake, would you like some time?
Not tonight, Rick. I see my doctor on Thursday, so maybe I'll have something next week.
And
New blood test results or whatever.
Do you have your questions lined up for your doctor?
No, I don't have any questions for her, really, to be honest.
Okay. Okay. Brian, did you and Ken Anderson, were you able to connect?
Yes, we were.
Fantastic. And what would you like some time tonight?
No, I don't have much new to report, actually. Well, I just had another PSA test, and it went down to 0.1. So
hello?
I guess it's going the right direction, but not much of a change from the 0.2. So
okay. New caller, I'll check in with you in a minute. Hold tight. I've just made a note of that, but that's fine. Dennis, would you like some time?
Yeah, Rick, I got some new results, and I've got doctor's appointment tomorrow, so give me a few minutes.
Absolutely. John Appler, would you like some time?
If you have time, Rick, it's not real important, but I just wanted to revisit this question of whether genetic tests, germline and somatic, are necessary for all high-grade cancers or just high-grade metastatic cancers.
Okay, yeah.
There seems to be some differing opinions about that.
Yeah, we can talk about that. Eric, okay. Would you like some time?
Yes, I would.
Okay. Jay Krugman, would you like some time?
Not this evening, Rick. Thank you.
Okay. Paul Frieda, would you like some time?
No, thank you.
Okay. Sylvester, how about you?
No, thank you.
Okay, now we have somebody new on the telephone that just joined us.
Yes, Harry Spila.
Sorry, what's the name? Paul, can you mute, please? I can hear you sharpening knives there. Thank you. I'm sorry, what was your name?
Harry Spila.
Carrie Spieler. And Carrie, have you ever been with us before?
No, this is my first time.
Well, welcome. Well, you may just ace out everybody, the other people. Since we only had 3 people that needed time, there will be plenty of time for everybody, even allowing for Peter Kafka when he gets here. Let me explain to you how we generally operate.
What was the name again, Rick? I'm sorry, I missed it.
Carrie Spieler. C-A-R-Y. I'm guessing, Carrie, correct me if I'm wrong. C-A-R-Y-S-P-I-E-L-E-R?
No, it's an H-H-A-R-R-Y.
Oh,
Last
Harry.
name S-P-I, yeah, Harry.
Harry Spieler. Okay? Spieler.
Thank you.
Okay. Excuse me, Harry.
No problem.
So what we usually do is, if we have somebody new, we spend 20 minutes to half an hour with them up front, and we ask them to tell us a little bit about their situation, their background, when they were diagnosed, what sort of treatment they've had, where they are on the journey, what decision points they're facing right now, and we just give you the floor, maybe only interrupt you just for clarification, and then once you're done, we'll have a discussion with you. So if you are comfortable in doing that, then you're very welcome. If you would rather wait a little bit, you're also welcome. But I do have one question. How did you find us?
From the Inspire website.
Excellent. Okay. Thank you. Thank you. Thank you. So are you comfortable in talking to the group?
Oh, yes, most definitely.
Okay. So take it away, Harry. The floor is yours.
Okay, thank you. Hello, everybody. I guess I'll start with the beginning. I'm currently going to be 58 years old. A couple years ago, in 2016, in the spring, I had a PSA that was, I believe it was 12, and that started things going. That was with my general practitioner, and I saw numerous urologists and specialists and decided to go with a prostatectomy. And I had that done in September of 2016 at Northwestern Hospital in Chicago. And the pathology report showed positive margins and the right seminal vesicle, and it was a Gleason of 4+5. So during recovery, about, I believe, 45, 60 days after surgery, I had a blood test taken, and a PSA was 2.79, I believe. And shortly thereafter, I started on my first Lupron injection, which was for 4 months. And that was in November of 2016. And then I've been on ADT since then. I've changed last year from Lupron to Zoladex, and that was only because of an insurance issue. But last year, I also had radiation therapy, 7 weeks, 35 sessions. That was in July, finished it the first week of August, or started in June, sorry, finished it first week of August. And I've been continuing on, and I'm kind of at a crossroads now. I had a follow-up appointment with my urologist/surgeon and also with my oncologist. And I've been having quite a few side effects from these drugs. And I discussed those with my physicians at this recent meeting. My oncologist is comfortable at this point if I should decide to stop the ADT treatment and to start monitoring it every 60 days to see where we're at. My surgeon, on the other hand, feels that I should stay on the ADT for 24 months from the date I ended radiation, which would be, another year from this August. So they've given me a bunch of data and studies that were done, and nothing, exactly fits my situation exactly. but there's similarities. So I'm at a crossroads. I have to make a decision, and it's a tough one. But I am also started working with a functional medicine practitioner who has been very helpful. I've been able to drop some of the weight I gained. I've started going to acupuncture. That's helped dramatically with the hot flashes. I've been doing some additional supplementation with minerals and vitamins and things, and so that's been really helpful, thwarting some of the side effects. But I still lost a lot of muscle mass. I feel lethargic most of the time. Sex life is gone. That was gone after surgery anyways. And just muscle soreness and not sleeping well. So a whole host of things. But the worst thing lately is short-term memory loss has been getting pretty bad for me, and that's concerning because I'm still active at work, got a full-time job, and that's somewhat disruptive. So anyhow, that's my summary of my story, and I'm just curious what other people's experiences are with the therapy and how long you're on it, and there's just so many opinions out there. There's no real guidance. As my one doctor said, it sounds like I'm a fraction, and he said, yeah, it kind of is. So that's where I'm at.
Okay. You've got a bunch of guys with a lot of experience on here that I know will share it with you. One thing you haven't told us, I have a number of questions, but the first one is, how's your PSA doing on ADT?
It's been at 0 or undetectable since I started ADT. Since probably, I think it was a few weeks after I started, it had already dropped substantially.
Okay, excellent. So you responded, not physically, but in terms of the disease, you responded ideally to the ADT.
So it's been working quite well.
Yeah. Now you say that your oncologist says that maybe you could take a break, and your surgeon says stay on for 24 months. When you say you're an oncologist, is that a radiation oncologist or a medical oncologist?
A medical oncologist.
Okay, and is that medical oncologist at Northwestern?
Yes, it's Dr. Hussein. She's quite well known.
Oh yes, he is. He is very well known. It's you've got one of the best, so it's hard to second guess it. I will tell you though that the new kid on the block there, Alicia Morgans, is doing a bunch of work into memory loss around ADT, and I would recommend that you communicate with Dr. Hussein and ask her if Alicia Morgans is running any trials or has any ideas for you, because she's supposedly doing a bunch of work. I think she's going to be publishing something soon, but it's an area that really interests her and is directly applicable to you. And these guys, see each other every day in the lunchroom.
Oh, so she's at Northwestern also?
She is. She joined Northwestern about 3 or 4 months ago. She joined.
Okay, I will ask.
She joined Northwestern from Vanderbilt, and she's really good. She's so good, in fact, that our treasurer, Rob Boniscus, who lives in Minneapolis, and has somewhat of a crisis with his treatment right now, flew in to see Alicia Morgans yesterday.
Okay.
Just for an appointment. So there's a bunch of guys on this call who have seen her. We're all big fans. She has a great manner. I think she's a little less formal than Dr. Hussein. Yeah. You know, I mean, at least that's. I mean, I've seen Mara Hussein present, and I mean, I've never met her in person, but she strikes me as being, I don't want to say rigid, but formal. And Alicia
Yeah.
Morgan's is a lot more friendly. I mean, I wrote her a note. I'd never met her, but I knew of her, and she knew of people that I knew. I wrote her a note. She responded to me right away, and she started with her first name, stuff like that. But anyway, I mean, I'm not
Yeah.
suggesting you make any switches, but what I am saying is that she's doing work precisely in this field of memory loss. Now, I um, I I did 28 months following my initial treatment, um, and I didn't have surgery. I had radiation, seeds, and IMRT. So it wasn't as if my disease came back right away. We have a couple of people whose disease has come back right away, and they have followed, and they'll talk to you momentarily. Um, but um, Personally, we don't give medical advice on this call. I can only tell you my own personal feeling. I personally think it's really important to stick out the full time. I mean, the studies, I'm familiar with a bunch of those studies. You know, 18 months is better than 30 months. 28 months is better than 4 months. You know, 24 months is better than nothing. The consensus over the past couple of years seems to be that you should stick on for at least 18 months. Don't give up before 18 months. And how long, when did you say you went on? You went on November of 2016. So you've been on
Right. So
not quite 18 months.
I'm at my 14th month
Yeah.
right now.
So,
Yeah. And just some of the logic that Dr. Hussein spelled out, we went through those studies, and a lot of those were done with, not with the injections, but with the Casodex, which they feel the injections now are more superior. So to that treatment, and I've been also taking Casodex along with the Zoladex. I've been on
you have.
both.
Okay.
Yeah. And so she's saying that combination along with the surgery and the radiation, she feels that, you know, if it's really up to me. I think she's letting me decide based on, you know, quality of life issues more than anything.
So, I mean, I'd say a couple of things here. First of all, the studies that I'm thinking of, which are the 4 versus 28, the 18 versus 36, and there's one other. Those were all with LHRH drugs, Lupron, Zoladex, Eligard, whatever it was. Those were not done with Casodex. I mean, I don't know what Dr. Hussein gave you, but the studies that I know, and I mean, I could send them you if you want them. I think I've got them bookmarked. Those were all with an androgen deprivation drug. Now,
okay, but those are all without prostatectomy, correct?
no, those were
because I think there's only a couple studies out there. One's in progress.
Those may have been with radiation and not with follow-up prostatectomy.
Yeah, there's one I know currently going in England. I think that's almost an exact match of my situation, but that's not going to be done till like 2020 or 2021.
Look, I mean, here's the way I look at it, and again, this is just my own opinion. You take the hormone therapy because you're concerned that there could be metastasis that has escaped the capsule. In your case, there was some action in the prostate bed because it went through the margin. There was some action in the seminal vesicles, and once it's gone that far, you don't know where else it's gone, so you're really fighting micrometastasis. Now, to me, that doesn't matter whether you had radiation in the first place or whether you had surgery in the first place. You're taking the you're taking the drug for the same reason. And while the studies may not be exactly matching what you did, I think that it's a good indicator how long you have to take the hormone therapy for. Now, there's a couple of things that I might discuss with her. One might be to drop the Casodex and see if that makes you feel better. And stay on the sit out the hormone therapy. I mean, I can only tell you about situations I've known over the past years where and I've been supporting guys now for close on 10 years. And I've seen guys get off the hormone therapy early, and invariably it comes back to bite them in the fanny. And the guys that sit it out, I'm not saying that they get a cure is maybe too strong a word, but they don't. But I'm not saying they all get a durable remission. But just anecdotally, I see them doing better. And you're already 14 months into this. I mean, before you're done with us today, we're going to give you a bunch of tips on how you can improve your life on hormone therapy.
Okay.
And because there are things that you can do. And and one of the sad things is that the doctors don't educate you when they put you on the hormone therapy. They just slam you on it, and you have to figure out what it's going to do to you. And you realize you're losing muscle, and you realize you're losing your memory, and you realize you're hungry all the time, and you realize you're gaining weight, and all these things, and you're retaining water. Yeah, it would be nice if they educated you about this, but they tend not to do it. Back at UCSF in 2010, it bugged me so much that I spoke with the head of surgery and the head of radiation, and we created we created a pamphlet, which is linked on our website. If you go to our website, ancan.org, you'll find it linked under related links, or if you, at some point during this conversation, you'll give me your email so we can put you on our list, and I'll send you the link afterwards. But the whole purpose of that pamphlet was to just educate men. And most of the men, not all, but a lot of the men who are on this call, one of the first things that they got out of this call was a link to that pamphlet, and they read it, and they learned a whole heck of a lot. And some of them had been on ADT for a long time before they joined the call. So, I think that there's a lot that's going on. I think, let's see, I saw that Len joined, and I see Tom Van Zant's joined. Maybe I'll ask Len. First of all, Len's situation is a little different from yours because he didn't have an RP to begin with, and he delayed his salvage radiation. But he's had a lot of trouble. He had a fair amount of trouble with the ADT, and he did persevere for quite a good period of time before first taking a break. Len, would you like to talk to Harry?
Sure. Hi, Harry. Apologize for tuning in late. I did hear that you were Gleason 9, 4+5, as am I. My experience on ADT spans, well, almost 4 years, maybe 3 3/4 years, but interspersed in there were 2 drug holiday breaks. So I've actually been on ADT for a combined total of about 2 years, about 24 months. And the most troublesome thing for me was the lack of mental sharpness and clarity, which it sounds like you're experiencing the same issue. And it sounds like that might be the most troubling for you. I was fortunate enough that I had already retired. So I can imagine if I was still trying to work that it would be even more distressing for me not to be able to remember things I knew I could easily remember before. the good news is that if you do get to take an ADT break, your mental clarity will recover largely, maybe not completely, but largely. Now, I'm 68, and sometimes now I have trouble discerning what's age-related and what's ADT-related. Yeah, I don't. The fatigue, the hot flashes were never much of a problem for me. The fatigue was a problem, not a major problem. It was mostly the mental lack of mental sharpness. So, as I said, the good news for you, I was never undetectable as you are, but I still took a chance on taking drug holidays. So, as your doctors told you, it's it's a lifestyle choice. It's your choice to make.
Right.
You have to go with your gut.
Yeah, the memory thing is very difficult. That's probably the one. I mean, the hot flashes and such. I mean, I could live with that, I guess. Not comfortable, but and then all the other stuff that's probably going on in my body that I don't even know about yet concerns me. So there's a lot of factors for me to think about here.
The one of the things that I really found helpful with memory was that I really challenge my memory on a daily basis. I don't know what sort of work you do, Harry. I do know that men who I've worked with who have had some really high-level responsible jobs, super high-level responsible jobs at Fortune 500, board-level Fortune 500, have found that they just couldn't maintain on Lupron and still keep their sharpness. I mean, for me, I wasn't in that situation, and I challenge my memory every day. I used to play some bridge, just because it made me force me to remember cards, and so I felt like I was challenging. Some guys do crosswords, Sudoku. I mean, the sort of thing that makes you think beyond the normal realm of your thinking, that stretches your thinking. Peter, I know you came in late. Harry had a prostatectomy in 2016 with positive margins, 4+5, seminal-vesical invasion. Followed it up with Lupron and within about 8 or 9 months, salvage radiation. So a very similar situation to yours, and is now trying to figure out how long he should stay on hormone therapy. How long did you stay on hormone therapy before you took your first holiday?
Okay, so I think it sounds like you're almost identical to me. I'm 2 years ahead of you. I started hormone therapy actually before my surgery, about 8 months before my surgery, and then I went off hormone therapy after surgery, and then made it about 11 months before my PSA started creeping up. Then I went for adjuvant radiation and stayed on hormone therapy after that until December of 2016, and now I've been off for a year and on a holiday. However, so I'm about ready to go back to San Francisco to get a gallium-68 PSMA PET scan, PET CT, because my PSA is starting to double, and there's signs that there's new activity. So my thinking is this: I would never second guess your. She's a great oncologist. I've met her at a PCRI conference a number of years ago. I think she's pretty astute. I don't think I would question that. I would never question a medical oncologist in terms of what her thinking might be in this. I don't think it's risky going off hormone treatment at 18 months. That's what essentially I did, but I did it in two spurts for the total of 18 months. I've enjoyed last year as a holiday. I had my testosterone came back. It was great. I'm strong. My mind cleared up. However, I know, and I hate to say this, but as a Gleason 9 with seminal vesicle invasion, I know for myself that the game is looking over your shoulder for the rest of your life. And I know that I'll probably have to go back on treatment, maybe even a second-line anti-androgen like Zytiga or something within the next 2 months. So I know the game is management, and I'm not surprised by it. I've come to terms with that, and I can live with that. So I've enjoyed the holiday I've had, but I'm willing to go back on it if that's what I need to do, and suck it up and deal with it. It's not fun being on androgen ADT at whatever level, but it's doable. You know, you got to drag your butt to the gym. You got to do Sudoku. You got to do whatever it takes to stay in the game. But don't get discouraged. I mean, we've been hit by something that none of us signed up for, but it is manageable. Yeah. That's my 2 cents.
Yeah. The question is, how many? The difficult. I don't know. I mean, I'm not even close to retirement yet. I'd like to make it to retirement. So that makes it challenging too, because my day's full with a full-time job, and my kids are still in college. But everything. Some of these studies, there is a difference. Obviously, I see for short-term or long-term hormone therapy after radiation, but the differences aren't that substantial. And amazingly enough, as far as people who die, but there's also people who die for a lot more other things than the prostate cancer in these studies, which is kind of amazing to me. But and plenty of people survive it too. And I don't know, they don't go into what condition they're surviving it through, but overall 10-year survival rate is pretty good on both sides of the equation.
How old are you?
I'm going to be 58 next month.
Oh, yeah, you're relatively young. I think you'll be okay. It's a tough one. Well, my attitude is, ADT, hormone therapy, isn't going to cure your situation. It's going to treat it. It's going to help you manage it. But I don't think you're going to get a cure. I have to be honest with you, and I've come to terms with that for myself. It helped me out a great deal. It bought me time for treatment decisions and stuff. But and I'll go back on it in a heartbeat if that's what my oncologist wants me to do, which I suspect he will. But I'm not going to pull the wool over my eyes and say I could have done it differently. I could have gotten better results. Because this, in our situation, your situation, my situation, you've had extracapular extension, you've had seminal vesicle invasion, and things are on the move. And the game is to try to stay away from metastasis. That's the main goal, and the hormone treatment is good for that.
Yeah, but the funny thing is, my surgeon urologist, Dr. Catalona, he still keeps using the word, we're still trying to work towards a cure. Now, he told me it's a tough one, but, he uses that term to try, it's like the carrot he holds in front of me to keep me on the ADT for longer periods of time. Right. So,
well, Harry, that we've discussed this, and I can't exactly tell you when, but I know that there are some really good discussions in the past on the YouTube website about cure. Cure is a tough word. Cure is a possibility for people like you or me when it comes back very quickly, very early, or you're treated with all this upfront. But I'd rather call it, I'm not a big fan of Snuffy Myers, but I'd rather call it durable remission. And, you can get durable remission. I think what complicates your situation, as Peter correctly points out, and where I would question Catalona, and again, you know, Catalona, Hussein, I mean, you got the dream team there, man. Um, you've got seminal vesicle involvement, and you've got extracapsular extension, and these are the sorts of things that make durable remission less likely, not impossible, but less likely. And you know, Peter's a good example because he did all the right things afterwards with doing enough ADT and doing the surgery, but eventually comes back. So you know, we don't want to discourage you, and I think Catalona has a reason to say. I don't like the word cure because I think the only people that get cured are people that have low-grade Gleason disease. I think if you've got a 4 in your number, it's hard to talk about cure, particularly if that 4 is in the first position. And I think durable remission, meaning that you may see your PSA go down to 0, but every year when you test, don't be surprised if it's risen. I mean, that's how I feel about my disease, which was 4 plus 4. You know, I don't think I'll never see prostate cancer again for the rest of my life. I'm curious what has been said to you about exercise and what sort of exercise regime you have.
I haven't been real good about that. It's been stressed to me about weight-bearing exercise. I was doing a lot of walking. I can tell you early on, after maybe the second injection, and during the radiation too in the summer, the combination, I was wiped out.
Mm-hmm.
I had no energy to do anything during that period.
Mm-hmm.
And even for a little bit afterward, it took me some weeks after the radiation to get to a point where, you know, I felt like I had some energy that took a lot out of me. So, and I'm a guy, I golf every weekend. I walk the course. Those things I had trouble doing this summer. I couldn't even do them. It was difficult. But I'm supposed to be doing weight-bearing training. I have not been doing it to the extent I probably should be. That's something I have to correct for myself.
Well, I'm not. I'm going to let a couple of other guys on here talk to you about exercise. I am going to tell you it is vitally, vitally important. And when you tell me you feel absolutely wiped out after the radiation, I know the feeling. I got that T-shirt. I can only tell you that if I would have been talking to you then and convinced you to take a 15-minute walk after the radiation, you would have come in and said, wow, what a difference. Now, we got guys on here who I've convinced to exercise during chemotherapy. And maybe some of them will speak up, but the one guy I want, since he's a golfer and he's been through chemo, he didn't, you know, his disease was diagnosed metastasized already, but he's been pretty good about exercising. Is Dennis Correa? Dennis, what can you say to Harry about exercise?
Well, for me, you know, when I would be really feeling tired and feel the fatigue and stuff, that was almost kind of like a signal that I'd got to go take a walk, or I got to get some exercise, do some resistance bands or something. And it works. And it's hard to stay consistent with it. I'll admit I'm not consistent with it. But I have other things. I'm 72, retired, so I got time to do this stuff. But I play golf 18 holes twice a week. So I use that as part of my exercise stuff. And when I'm done with those 18 holes, I'm exhausted. I'm no good for anything for the rest of the day. That's it. Just may go home and snooze a little bit or something. But it does work. And the signal for me is when I'm feeling lethargic and tired, I know I got to go get some exercise. And it's not always that easy, you know, depending where you live. I'm fortunate, again, I'm down here in Tucson. So we get the weather. I can just pop outside most days and do my little walk for 15, 20 minutes, and I'm kind of recharged again.
Anyone else on the call want to talk about exercise and fatigue?
Hello, this is Brian. Harry, and the rest of the group. As you know, I just recently went through chemo this past summer, and then followed up with radiation about a month and a half after that. And I was struggling a lot with fatigue as I got further into chemo, and was really encouraged by my primary care to exercise every day. And that was difficult, obviously, especially in that first week of the chemo. But I did try to do some exercise, whether it was walking, just walking especially. And over time, I noticed that it was helping my just overall outlook as well. My mind felt a little sharper, and I just felt better over time. So I think it helps a lot of areas. I don't know what others' thoughts on that are as well.
Thanks, Brian. Jay Krupman, there's a sort of similarities to your history here. Do you have anything to contribute here?
Well, it is similar. My PSA was a 743, and I had clear margins on my prostatectomy. I did have radiation about 6 months after my surgery. That didn't take care of my situation, so then I started on hormone treatment. I only took 7 months of treatment. I started on Firmagon, had 4 monthly shots. Then I had a 3-month shot of Lupron, and my PSA was non-detect about 4 or 5 months after I started the treatment, and I had 2 clear PSAs, and my side effects, and is mostly cognitive, I felt were not worth the continuing the treatment. So after 7 months, I left that program. It has been, I was looking up the dates here. It was about 7 months after I stopped treatment that my PSA started came back very slowly, had a couple of 0.01 tests in January and February of 17. Then it started rising in May. It went to 0.06, 3 months later 0.2, going on, and right now it's last one I had was first of the year was 1.2. So I'm expecting it to, I got an appointment in 3 weeks now. I'm expecting my PSA to probably be in the 2 point something range, and I'm having to make that decision as well, Harry, as regards to going back on the treatment or continuing to stay off of it. My side effects seem to take, and I've heard it before, and it was very accurate for me. My side effects diminished and were about gone the same amount of time I was on the treatment. About 7 months it took for me to get totally clear. So the last year or so, I've been doing fairly well with everything. I guess I said the memory and the mind game just was what was really getting me. The hot flashes were okay. Didn't like them, but they're tolerable. Had some severe fatigue at times. I tried to go to the gym at least 3-4 times a week, and I believe that helped. I'm not a big weight person, so trying to do that is not like what I like to do. I'd rather do aerobic, but so I'm in that same or in the position trying to figure out if I want to stay off or go back on. I know Rick's a fan of staying on for the 18 months or longer. I just don't know what I'm going to do right now. I probably will be starting treatments again here shortly. I did meet with Dr. Morgan's up at Northwestern in October. That's when she started up there, and unfortunately, she's not my network. I really do like her, and have considered trying to get with her, just staying, out of network cost. So,
Jay, did you talk to her about memory loss at all?
No, we really didn't get in that. It was more where do we want to go, and we didn't get into specifics of the side effects. It was much more what her study and her areas with her father going through lots of things and everything else, and how to manage the side effects. But we never got specifically into the memory stuff.
So, Harry, you got a pretty good idea of how we function on this call now, and there's just a huge amount of knowledge and experience. What I would
I don't want to take up all the time. I'm sorry.
What I would encourage you to do is just to keep coming back to us, keep bouncing ideas off of us. You can, before you've got an appointment, talk to us and, let's talk about the questions you're going to go through, etc. There are a lot, we don't have time to go through a lot of stuff right now, but as you keep coming back and you want to raise issues about exercise or diet or memory or stress relief, we can cover all of those. I don't have you came on by phone, so I don't have your email address. If you're not comfortable giving it to me over the phone, you can email it to me at info@ancan.org. N as in Nelson, C as in Charlie, N as in Nelson.org, ancan.org. We'll add you to the distribution. We send out a note before every meeting. We meet every week. You can attend as frequently or infrequently as you like. We welcome you here. So you're with a bunch of brothers.
I appreciate everybody sharing, and if I can just ask one quick question,
please.
Before I take up too much more time. Does anyone have any experience with taking different durations of injections? There's a 3-month, 4-month, there's a 6 months even. If I do move forward, I'd like to just get a 6 month, but I don't know if there's some, are the side effects worse with a 6 month, or does it make a difference?
Well, I'll answer that and then I'll throw it open. My only experience is just the first couple of days, because the larger the shot, the more uncomfortable it is to begin with.
Okay.
But I don't think it makes a whole heck of a lot of difference. What did you? Oh, you're on Zoladex right now, is that right?
Yes.
Yeah. So I guess you can get that as a 6-month shot. You can get that as a 180-day depot.
Yeah.
No. Anyone else have different experiences with different terms of the shot?
Yeah, this is Tom Van Zandt, and I've been on 6-month Lupron almost the entire time, and because we talk on here, I hear a lot of people say they're on 2-month, 3-month, 4-month, whatever. So I asked my doctor about it, and he said, well, some of that is to see the first time how a person's going to respond, or if a person's not going to be on it that long. But they said once you're going to stay on it, you're better off to get the 6-month shot and get less shots. Now, I usually have a little bit of, not a little bit, some extreme soreness after the shot, where I finally learned to take heavy ibuprofen for about 2 or 3 days. And if I don't take it, I can barely walk and got so much pain I can't sleep at all. Just local soreness, But I think I'd much rather get a 6-month shot than go back every 3 months to get it.
Anyone else?
I'm a fan of the 3-month shot. I don't know why, but it gives me a chance to check in with my urologist a little more often. Yeah, it's 3 months was reasonable for me. I did Lupron, not Zoladex, and I had no trouble with it.
I agree with Peter. This is Len. I had some 3-month injections. I think Tom Van Zant's experience with the Lupron shot is atypical. I felt absolutely no pain whatsoever with 3-month shot. And don't forget, these are pharmaceutical depot formulations. The longer you go out, like 6 months, it would seem reasonable to me that the less likely there'll be a nice, even release of the drug over that 6-month period. So I would advise 3 months.
Yeah. Well, thanks for your opinions.
Okay. All right.
Sure.
So go ahead.
Brian, I just want to ask a quick question. Harry, where are you located, if you don't mind?
Chicago area.
Okay, because I'm in the Chicago area too. I'm actually out in Bartlett.
I'm in Palatine, so I'm just north of you.
Okay, all right.
Well,
Thanks.
I'll if Harry, if you send me your email address, I will. First of all, I'll send you a link to the hormone therapy pamphlet. Although, like I say, it is linked on the website, and I can connect you and Brian if you would like.
Okay, great. I'll send you my email. It'll be easier than I'm in the car right now. So.
Fine, no problem. No, absolutely no problem. So
Thank you, Rick.
Okay.
you're in Palatine, and where are you? Where are you, Brian?
It's in Bartlett. It's spelled Bartlett.
Yeah. I went to school in Chicago, so I know a little bit. I know the area. I went to grad school in Chicago, so I know the area a little bit.
Oh, okay.
Where'd you go?
U of C. I was holed up in Hyde Park for 2 years. So, but I heard about these names, like Palatine and Bartlett. You do hear about things when you're in Hyde Park. That's about all. You don't experience much, but you hear about things. And you get to be good friends with the IC. So, all right. So, let me just check in with the people that joined since we started talking to Harry. Len, would you like any time tonight?
I don't need time, Rick. Thank you.
Tom Van Zant, would you like any time tonight?
Looks like he stepped away.
Looks like he stepped away. We'll come back to him. Peter.
Yeah, there he is.
Oh, Tom, would you like any time tonight?
Just wanted to say that I sent a letter to the oncologist, and I thought he ignored me for a couple days, but he gathered up my case information and called me at home about 8:30 at night.
Can we come back to you? We'll come back to you. We'll give you
Sure.
a little bit of time. We'll give you a little bit of time. Peter, I know you would like to say something tonight.
Oh, only if there's time. There's nothing pressing, but only if
Okay.
there's time.
And Larry Fish, would you like any time tonight?
No, thank you, Rick. I'm okay tonight.
Okay. So let's kick off with Dennis. And then we'll go down from there.
Okay, just more good news on my Zytiga treatments. My last blood sample I took last week, my PSA has gone down another tenth of a point to 0.2. So it continues to work. The only thing of maybe some concern is, I'm looking at the data for side effects on Zytiga, and one of the most common is increase in triglycerides and also increase in two liver enzymes, the AST and the ALT.
Right.
And for sure, mine are increasing.
Right.
So at this point, I don't suspect that this is anything terrible. Only one of them is outside the normal range. The ALT is 78. Normal range is 5 to 60. The other items are going up. I'm not sure what the triglyceride is, but mine is up to 135.
Are you on a statin?
I am not.
Well, that's probably, I put that way up on your list for your guy tomorrow then.
Okay.
You know, and the statin of choice has always been Crestor, for a number of reasons. Probably the biggest is because it has the least interactions with other drugs.
Yeah, I may have to. I brought this information up before to him and told him I was going to see my GP, which I did, and asked him about it, and he wasn't ready. He wouldn't prescribe it.
You know, I would have thought if your oncologist knows much about prostate cancer, there's all kinds of information that suggests that you should be on a statin with metastatic prostate cancer. And one of the big reasons is because that one of the building blocks of cholesterol is testosterone. So
right.
The way that the Zytiga works is that it stops the cancer from extracting the testosterone from your cholesterol. So, you know, you really want to keep your cholesterol pretty low. And, you know, I just had a online argument with Mike Scott about statins. You know, he seems to think they have a heavy side effect profile. I don't necessarily agree with that. But what I would say to you is that, you know, there's good reason to be on a statin. And one of your docs should be putting you on there, and rosuvastatin, which is the generic for Crestor, is now readily available. I'm getting rosuvastatin. It's not costing me a dime on my medical plan, and I can eat grapefruit. So you know, I got a double whammy because I was on simvastatin. Now I also have a genetic history of very high cholesterol, largely because my good cholesterol is very, very high, and so that pushes it up. But I would really push to get onto a statin. If it were me, I'd be pushing to get onto a statin.
Okay. I'll bring that up again. Maybe he can give it to me, the prescription for it.
Yeah. Anybody else want to talk about statins and adding statins to your treatment?
Quick question, Rick. Is Crestor equivalent to Lipitor, or is there a difference in the interaction level of those two drugs?
No, it's not. Lipitor is a different drug. I forget which one is Lipitor. I'll look it up, or maybe Len will tell us in a second. What?
Yeah, Lipitor is a atorvastatin.
Atorvastatin, that's right. So the preferred, if you can get it now, is rosuvastatin, which was Crestor, and everybody should be able to access that as of the end of last year. It went generic.
Thank you.
Has anybody else had pushback from their docs trying to get a statin when they've had advanced prostate cancer or recurrent prostate cancer? Well, see what you can do, Dennis. Put the script.
Yeah, because my situation was similar to yours. I have very high good cholesterol.
Right.
Which gives me a higher overall, you know, cholesterol level.
Right.
And his theory was that that's a protective mechanism, that good cholesterol.
It is.
So although mine was above the limit for total, he didn't think I'd need the statin. And I had used simvastatin prior, and I had felt like I was getting some muscle aches, and I asked if I could, try stopping it. I stopped it, and I didn't have any more muscle aches. So
the muscle aches are a problem. I mean, there's no question, but the muscle aches result.
Yeah, and that was before my diagnosis.
Right. So I mean, yes, muscle aches can be troublesome. But what can I say? It's your call. It's your call. Yeah. But I would want to be on it, just like I would want to be on metformin to control glucose. Now I can talk to you a little bit about ALT and AST because it is a side effect of hormone therapy, of ADT, and my ALT and AST levels were high the whole time that I was on hormone therapy, and made me feel kind of crummy, especially in the morning, like what in England we would call liverish. But I can't translate. I cannot translate that. But if you said I feel liverish to a Brit, they'd know exactly what you meant. But you feel like slightly nauseous, not really nauseous, but a little bit nauseous. You don't really want to eat in the morning, until you've been up a couple of hours. You don't feel.
Not me. I can't wait to eat in the morning. Unfortunately, that's when I take my Zytiga, so I got to wait an hour. Take it.
But I never did anything about it. It was always a little over 100, and eventually, after I stopped the ADT, it went down.
And also the other thing goes along with that. When I had my gallbladder removed, 5 years ago at least, one of the observations they made was my liver appeared to be a fatty liver, which was kind of surprising. And I guess there is a form of fatty liver that's not attributable to alcohol consumption. I'm not a big alcohol consumer, and right now I'm not a consumer at all of alcohol. So I don't know. We'll see if he wants. I don't know. We're at the level where I need to do any liver function testing or anything like that yet.
Anything else that you would like to raise for your appointment for tomorrow?
The other issue I had, and not necessarily related to the appointment, but I have Humana for my drug, my drug plan, and they have their own pharmacy that make this Zytiga. Well, I guess they compound it have the right from Janssen or whoever it is that makes it. And they express mail it to me, overnight mail, and I get it the day I'm taking my last dose every month. And this past month, they missed it, even though I'd been checking with them several times a week or so before, 2 weeks before. And their claim was that somebody missed doing some kind of reauthorization with the insurance company. Now I buy this, it's from a Humana pharmacy, specialty pharmacy. And I have Humana also as the insurance. So I guess they had to check with Medicare too, because I'm on Medicare, it's my Part D. But it's kind of a little anxiety raising. So I let them know about this and no uncertain terms, but I don't know if it's going to change anything. But getting it and waiting and then not getting it. So I did miss a day.
Right.
And I told my doctor, because it says on my drug information about the Zytiga, don't stop taking this stuff suddenly. Same with the prednisone,
right,
which comes also the same way, and but I had extra prednisone for a day.
Good.
And I talked to the doctor, and he says, well, if it comes before a certain time, you can take it, but after that time, wait till the next day to take it, which is what I did. So I missed a day, and then, you know, just the anxiety of right after that, having to go get my blood work done. I said, oh, gee, now I'm going to be going back up on my PSA because I missed a day as I take or something. But that, luckily, that didn't happen. But just a little anxiety stuff, which I don't need to.
No,
have.
No, I think it's good to talk to the people at Humana, and I think you've got to stick on their case. I mean, I would also ask them for a little backup on the prednisone, because you don't want to stop that prednisone cold turkey, and that can have effects pretty quickly. So,
right.
And I know guys that have suffered from that. So you've got to be really careful with the prednisone. So, you know,
yeah, I think they do give me an extra day's dose, two pills extra.
Yeah.
When I get it.
Yeah. Okay.
They're tiny little things.
Yeah. Yeah. All right.
That's about it.
Good luck tomorrow. Keep us posted.
Will do.
I'm assuming that you're seeing your Tucson doc tomorrow. You're not going up to see Steve.
No, I don't go up there till March.
Okay. My guess is that you could get my guess is that he'd give you a prescription for the statin in a heartbeat. That's just a guess.
Right. Yeah.
Okay. Moving along. Eric, you're up.
Well, hello. So I've had another visit to another couple of visits to the ER.
Oh.
Actually, on last Monday's call, I was in the ER, and you never saw me on there because I was just on the phone, and then the doctors kept coming in, and so I had to hang up. But I spent, excuse me. Frogs in my throat. Uh-oh. Only getting worse. So I spent 3 more days in the hospital, starting out in the emergency room, and not getting much cooperation from the doctors. I had one lady doctor who had a heavy accent, came in first thing in the morning, and then I never saw her again. And I kept having to pump everybody for the results of all the tests they were doing. They probably took 20 tubes of blood, and they had a CT scan and a chest x-ray and a sonogram of my lower abdomen, and they never came back with the results. And in my discharge papers, they said, oh, here, take this antibiotic. And I said, well, what am I taking the antibiotic for? And they said, well, you have strep. So it was not very satisfying. So the day that I went into the hospital, my blood pressure, when I first took it, was 73/55. It went as low as 71/52. And I finally got to the point where it was too bad, and I just went to the emergency room, and they kept me there for 3 days. Still not figuring out anything in particular. There was a mass in my lung, which showed up in a chest X-ray, but it cleared up by the time I had the CT scan. So they think that maybe it was some pneumonia, because that's what they thought I had when I went in before. So they increased some of my dosages, gave me a pint of blood, and it must have been 6 liters of liquid, normal saline. But you know, I didn't leave with a very satisfied feeling that anything really had been taken care of. And you know, when I went in last Monday and they hydrated me and sent me home the same day, it was okay for a couple of days, and then my blood pressure dropped down to nothing again, and I had to go back in. So I went to an endocrinologist, and so before I went in this most recent time, I called the endocrinologist, and he upped the dosage of one drug and prescribed a new one called midodrine, also known as proamotine, which was also supposed to increase my blood pressure. And I was taking that, and the blood pressure kept going down. So I gave up. And, I don't know how many times I'm going to have to do this, but I certainly aren't figuring things out. The cancer center in Berkeley offered to just set me up for a regular hydration routine, and that might be the way to go, because getting hydrated does seem to bring the blood pressure back up, unlike any of the 3 or 4 drugs I'm taking. So that's my update.
Where were you in hospital?
I went to Alpha Bates in Berkeley.
I mean, do you think you might be better off if you checked yourself into UCSF?
I couldn't be any worse off. Next time I will. It's just, the transportation is a little bit difficult, and it always works out to be rush hour when I want to go in. So.
Yeah, I mean, at least if you're in UCSF, you've got you've got Agarwal and others that are kind of aware and kind of watching over for you. And I don't know who's watching, especially now that what's her name has left.
Well, I do have someone who's watching over. He's the one who suggested the regular scheduled hydration. His name's Gabriel Schwartz, and then I have a new person that they've assigned, whose name is Uma Suratdevara, who I have not met yet. She's the new medical oncologist that they've assigned me. I haven't met her yet, so I don't know whether there'll be someone I stick with.
What's her name?
Uma. And the last name is spelled Suryadevara.
Okay. I don't know. I mean, it just seems to me, given your disease is pretty complicated, that if you can get your treatment at UCSF, if you have the opportunity to do that, it's got to be a better option. That's my gut. When did you get your last Jeptana, and when are you getting the next one?
The next one's on the 1st, and the last one was basically 10, 12 days ago.
So how soon after your chemo did you have the issue with your blood pressure?
Well, I had it on, I got the chemo on Thursday, and I went in the emergency room on Monday.
And did you let Agarwal know?
Yes.
And what was his thoughts?
He just acknowledged it. He didn't give me a suggestion.
Well, maybe again, I push him a little bit and say, look, is there a pattern there? Does your blood pressure tend to drop right after you get chemo?
Well, they give me steroids, and I think that the steroids, the Decadron they give me, keeps the blood pressure up.
Well,
and then maybe when that wears off.
Yeah, and then when that wears off, is that when you have the issue? Because I would sort of dig into this a little with Rahul and ask him and say, look, especially if you can see a pattern there, where you're getting the chemo, you're getting the Decadron, and it wears off, and then your blood pressure goes to pot, and then you have issues. and see if you can come up with some sort of a plan with him. Maybe you need to titrate off the stronger steroids.
Right.
And you know, it's worth dropping him a note and asking him what he thinks, because you don't want to be in this situation each time.
Right.
Anybody? Can I open it up? Anybody else want to chip in here with for Eric? We did see you, by the way, Eric. We saw you very briefly last Monday, and then we came back to you and you weren't there. So, anybody want to talk?
Yeah, Rick.
Yeah.
This is Len. Hi, Eric. I'm just curious. It sounded like you were saying when you have these hypotensive crises and you go to the emergency room that they hydrate you. They run IV fluids. Do you not normally drink a lot of fluids at home? Do they tell you to drink more fluids?
Yes, they did, and it doesn't seem to help.
Uh-huh.
I drank. Well, the hospital told me to drink Gatorade. The oncologist told me to drink Pedialyte. But
anything with electrolytes or salt.
Right. So I was mostly drinking Gatorade, and I would drink, 5-6 glasses of that or more a day, and it doesn't seem to make a difference. So it just, I don't seem to be able to absorb the liquids properly.
Right.
Well, I do think it's worth, maybe getting Dr. Agarwal on the telephone and having a chat with him.
Yeah. Yeah, my next appointment with him is in it's either 3 or 4 weeks.
I wouldn't wait that long to talk to him about it.
Right.
I mean, I definitely would, be talking to him well before you get your next chemo. Are you going to get that chemo at Outer Bates or at UCSF?
Outer Bates.
Mm-hmm. So but I would definitely talk to him before you get it. And the other thing is maybe talk to him about. And are you getting it with Carboplatin yet or not?
Oh, I started out with Carboplatin.
Oh, that's right. They
added
Carboplatin. Yeah.
Jeff Hanna with it.
Yeah. Well, you may want to talk about dosage as well with him, but I'd have a little chat with him, definitely. May the force be with you. It's just miserable and it's so frustrating. If we could at least figure out this low blood pressure issue, it would be something. But I just wonder if it is tied to, reaction to the steroid dose together with the chemo. I think it's worth a discussion. Okay. Anybody else want to talk to Eric before we move on?
Hi, Larry Fish.
Go ahead, Larry.
Eric, I don't know. It's more kind of empathetic with the complexity of your situation, and thinking that they can't. When you check in, they just deal with what you check in with, the low blood pressure issue. They don't seem like they try to dig in deep and figure out the complexities of starting Jeftana on top of Carboplatin and plus the prednisone, the shot. One thing that I did do when I was having trouble on chemo, which was just Taxotere, is I did convince my doctor to give me these 2 milligrams of Dexatron, I guess, Decatron, to be able to wean myself down so I didn't come off abruptly. He added a prescription, let me go get 30 pills, and I would sort of go down to 4, maybe take 4 the day after, 3, 4 days later, and then 2, and then 2, and then try to stop. And I held on to those 30 pills, sort of manage them just with how lousy I was feeling. Now, I don't know if that's something you can discuss, but just that idea of having like a little backup of Decatron or whatever it is that you're, that's just the only thought I had.
Yeah, that's possible.
Yeah, I mean, it relates exactly to what we were just saying, that maybe you need to wean off the Decadron, and clearly that was a strategy that worked for Larry. So I'd be talking about it for you and see if you do better that way.
Right.
When was the last time? What's going on with your PSA? Weren't you? I'm just looking here. Weren't you up around 50? I seem to remember.
My PSA's been going down.
Okay.
So yeah, it's down to 14.8 now.
Oh wow. So I'm just looking. I'm trying to see. The last time I have a PSA number for you was probably back around sometime before December, and it was above 50. So now, your PSA is now down to about 14.8.
Yes.
So that means you're responding to the Jeff Tanner and the Carboplatin. Do we know which one, or we're not sure?
No, we're not sure.
Okay. Well, that's good.
It was up as, let's see, in October it was 48.50.
Right.
Then a month later it was half, 22.90. Then it went up a little bit, and then the last couple of them have come down to where it is now, 14.8.
Did it start coming down on the Carboplatin alone, or did it, or not?
Yes, it did.
It did. Okay. Well, all the more reason to try and figure out a way to keep you stable when you get your chemotherapy. Definitely talk to him about this, about Larry's idea. I think that's a dynamite suggestion from Larry.
Okay.
And thank you, Larry, for raising it. Okay. So we'll move along. Tom Van Zandt, tell the guys about the letter you sent, because I know you sent me a copy, but they didn't see it, and tell them where you stand.
Yeah. I was talking to Len Sierra. I got an idea from talking to him that perhaps I could get pelvic girdle radiation and get off Lupron and Zytiga for a while, because I've been on it for 5 years and just get very, very tired of the side effects. So I did talk to Len and compare notes with him on my exact condition, and Len noted right away that some of the lymph nodes that I had involved were a little higher than in his case, and he was allowed to get the radiation. He had to push a little with the radiation people over the objection, well, not objections, but he went direct to them. But and at any rate, I sent an email to the medical oncologist at Fox Chase and asked him if I could do that, and he took a little while, but then he did call me at home. I could tell that he had my case right out on his desk, and he was looking at all the ins and outs of it, and he told me, no, it's not for me, too bad, you lose. But he said the lymph nodes are too far up, and he said I could go through that procedure with all the risks of radiation and probably not the benefits that Len received. And he said, you go off Lupron and Zytiga, and almost surely the other lymph nodes are going to pop up. He said, mine is too far spread through my system. perfectly under control with ADT. But he said when you go off it, it's going to pop right up. And he said they'd like to reserve the radiation for when things start getting out of control and they can go after specific lymph nodes with it, rather than radiating the whole pelvic girdle for what he feels would be no good purpose.
Well, there's an opinion. I don't know. I think what I might want to do. This is just my idea, but I might seek a second opinion on that from someone else.
Well, that's about the third time I've been told the same thing, where I say, hey, how about we do radiation? And they go, how about we don't?
Always at Fox Chase?
No, Fox Chase and Memorial Sloan and Johns Hopkins.
Oh, wow.
None of them
wants to do it. Who was it that at Sloan that suggested that you don't do it?
I don't remember his name. He was an older man, and I remember he was. I must have been like a borderline case, and he wanted to get it for me, and he got on the line while I was there with the radiation department, and he talked to them for 5 or 10 minutes, and he got off, and he said, "Nah, sorry." They say no deal. They say the radiation it would take in your case, you would receive too much radiation, and they do more harm than good with it.
Len, what do you think it's worth a shot at Boris or not?
No, I think that the docs are right in this case, Rick. I think even full pelvic girdle radiation will not reach those para-aortic lymph node involvement that Tom has. It's just out of the field.
I see.
And
okay.
Yeah. And even if they were to attempt it, I imagine he'd have some pretty nasty intestinal side effects.
Right.
Going all the way up there.
Right. So
it's hard to argue against Fox Chase, Sloan, and Johns Hopkins.
Yeah. And what about a holiday? Did you discuss a holiday with him, Tom?
Well, I told him that the whole point of my asking for consideration of radiation was to get the Lupron holiday because I'm so sick and tired of the side effects of it. And again, he said, I hear you, I understand, but I do not recommend. He said, as soon as you go off, this thing will take off like a forest fire and you will be sorry.
Okay. What to say? I don't know. I think
it's more that I just have to make the mental adjustment. That's the way it is. I should feel fortunate that I have a nice little remission going with the Zytiga. Not a bad quality of life. I got my gripes, but things could be a lot worse too. So I better learn to live with what I have and like it.
How's that exercise going? Are you chopping wood?
Really, I sloughed off on the exercise because I had, I don't know if you call it a mild flu, I guess, which I had for about a week or so. And so I haven't been exercising as much as I should. I have to get back to it and start again.
Okay. Well, maybe that'll brighten you up. You'll feel better for it.
Yeah, I'm not depressed. I just, my main complaint with the Lupron is the sleep, how it affects your sleep.
Well, thank you for the segue. Thank you for the segue. So next Monday, for sure, and I will be advertising. I just haven't gotten to doing it yet. Next Monday, we're having a plenary on cancer and sleep, and it's going to be given by Dr. Ruben Nyman, who is a clinical psychologist and an integrative practitioner. He practices with Dr. Andy Weil at the University of Arizona Integrative Medicine Center, and he lectures to the med school there. He also lectures across the country and internationally. And Dennis has heard him, and we are going to try and hone him down a little bit more and specifically have him talk about issues around cancer and sleep. Now, he has some interesting ideas on this, and I'm not sure that, you're going to find the Holy Grail, but you might pick up some really good tips. There will be a slide deck. We'll post it for those who want to join by phone. We can have up to 50 people join on GoToMeeting, and Ruben will present. He'll take over the presenter screen. But I think this will be a really good session, and there will be plenty of time for questions. So the easiest way always with these sessions, if you have questions, is to send them to me ahead of time, because it's not always that easy to, when you've got so many people, and because we have a pretty crude platform in GoToMeeting, it's not as easy to take questions at the time. But we can do it. We can do it with the chat window, or you can email us or what have you. But I think it'll be a really, really good session. We're going to advertise it to other cancers as well. And he recognizes, Ruben recognizes that, there are a lot of issues that arise when you have a hormone imbalance that affects sleep. And he will talk about that. So, maybe, how much snow do you have out there in Western Pennsylvania or wherever you are?
I'm in Northeast PA. We just had 5 or 6 inches, but then we just got a little warm spell and it's all gone.
Oh.
Right now we're having ice jams on the rivers.
Oh, ice jam. Well, no, because I was going to say you could get yourself a pair of snowshoes and start. That's good exercise.
Yeah, I have cross-country skis, and if we could get enough snow down that would stay, I go out with the dog and do cross-country skiing.
Oh, that'd be fun. And how about that chopping wood? Are you chopping wood there, Mr. Van Zandt?
I used to do a lot of that, not so much anymore. I did help a woman who's, about 68 years old, and she gets by only burning wood. So this summer I got my trusty chainsaw out and sliced up some stuff for her, and both of us were beat by the end of that day.
Okay, just making a few exercise suggestions here, sir.
Where in Pennsylvania are you, Tom?
Pocono Mountains.
Oh, okay. Nice area.
The ski resorts in the Pocono Mountains, as I recall.
Yeah, I live right near the Camelback ski area.
Oh, okay. Okay. Well, it must be pretty, even if it's slushy. So.
Pretty crowded on the weekends.
I bet it is. Well, I mean, it was in the 20s overnight here last night, and it hit 70 degrees during the day. So we have a little of all that weather. So, okay. Now I think John, I left John and Peter to the end because they were less pressing, and I think John left us. Yeah, I don't see John. he wanted to talk a little more about genomic and somatic testing. We really need to get one of our experts on the line to have that discussion, but I'm not exactly sure what was on his mind. But Peter's still with us. And Peter, we have 20 minutes.
What do you mean by that? I hope I'm still with you.
He's still kicking.
Alive and kicking.
No missile alerts today, Peter?
What was that?
No missile alerts today?
No missile alerts. No, we're all right.
Did that missile alert affect Maui, or was it just the Big Island?
No, the whole state.
The whole state?
Yes.
What did you do, Peter?
Well, I slept through the first alarm. I only woke up for the all clear.
Nice.
So we had a good laugh, imagining what people, but some people really freaked out.
Yeah, I heard they were sending death threats to the people involved with the false message going out.
No doubt, no doubt. Anyway, it's all passed. So two quick things. One is I'm all signed up now for gallium-68 PSMA PET-CT at UCSF, the trial. I'm going to do it on Monday, the 26th of February. And I was really pleased with how fast and efficient and they all were. And actually, I came at it from two different directions. My oncologist down in Marina Del Rey requested it, as well as Peter Carroll up at UCSF. So it's all good to go. And the main thing is they warned me to stay off of ADT until after the scan. So I'm going to do as they say and stay off of it and just check my PSA next month before I go, and then go over for the scan. And I'll probably meet with either Dr. Carroll or one of the radiation oncologists at the end of the week and go over the results before I go down to see Dr. Turner and go over the results with him and come up with a plan of action. So that's my situation. I just wanted to mention, we had our
let's hold on that one a second. So and it's costing you $900, is that right?
Right, $900. The insurance doesn't cover, or the trial doesn't cover.
Okay.
And my insurance, they'll try to bill my insurance, but I don't think my insurance will cover it.
Okay. And what are the eligibility criteria for this scan?
I don't have it all right in front of me, but it's you have to have rising PSA. You can't be on any androgen deprivation. You've had to have either surgery or radiation, or in my case, both. Yeah, more. I guess I don't know what their criteria is for rising PSA, whether it's just the rise or the doubling time. I gave them all my stats for the last 4 months, and they told me I was certainly eligible. So it wasn't so much a finite number. It was probably the doubling time or the progression.
Do you have to have evidence of metastasis, or
no evidence of metastasis. I think that was one of the criteria too, that there was no evidence of metastasis.
Okay.
So that's where it is. I mean, there might be some others. I gave my copy of the thing away. I've got to print a new one up, so I don't have it in front of me. I gave it away about an hour ago. That's my next quick story.
Okay.
Okay, so as you know, I moderate with Ken the low and intermediate call, and we had ours yesterday, second and fourth Mondays. We had 9 guys, and Amazingly enough, four of the 9 were people from Maui.
Wow.
So, yeah, so we've got our own quorum going here on the phone. 2 I'd never met. I mention this I don't want to talk about people's situations per se, but I just want to talk about it in a larger framework. One of the guys I talked to on the phone a number of times. He's been on a couple of our calls. I'd never met him before. Lives near me, and he went over to Dr. Sperling in Florida for FLA treatment. He was a Gleason 7 3+4, and he felt it went great. He had a wonderful experience with it, and felt really good about Dr. Sperling and everything. Anyway, so we arranged to have coffee this morning, just before the call today. I just came back from it. I met with he and his wife, and while we were having coffee, first thing he did was show me his pathology report and so forth, from his report from Dr. Sperling. And I looked at it, and the first sign to me was his PSA, which was up in the mid-20s. And I perked up my ears at that. Said, what's up with this? He said, yeah, it's a little bit high. Sperling was concerned about it, and it was something like 17 going in. Now it's 26, and Sperling thought maybe it was just the FLA stirring things up or something. Anyway, but they did a scan of him and spotted something on his spine. So Sperling did a biopsy, a bone biopsy on him. And while we're sitting there having coffee, the results come in, and sure enough, it's a positive scan. A positive biopsy. So we're sitting there, and all this. And the story is that yes, I moderate the low and intermediate call, but things can go south really fast, and you go from low and intermediate to advanced in a heartbeat. So, so my radar is up all the time. Just because someone says they're a Gleason 3+4 or even a Gleason 3+3, I have to remain vigilant and alert, and really make sure these guys are getting the treatment they need and the treatment they deserve, and are checking everything, checking it twice, because it's a crazy disease, as we all know, and so that was my lesson today. That all of a sudden, we went to have coffee to celebrate the successful FLA, and ended up giving them all my research material and writing names of doctors and oncologists and this and that, and kind of helping them strategize his next step, because the game changed all of a sudden. So that's my short story.
What is FLA again, Peter?
Focal laser ablation.
Okay.
Focal
kind of blast.
So Peter, are we going to corral this guy onto this call, or are you just going to work with him, or what's he thinking of doing, or is it all too new?
I think it's all too new. I mean, the bottom fell out there. His wife was right there. It was just an interesting experience.
Sure.
Yeah. I'm glad I was there.
How old is he?
68.
Okay. Well, he's got a lot of good options, and he's very lucky to have you on Maui with him. So, hopefully we can steer him in the right direction and get him taken care of, and get him into good treatment. I mean, he was, as I recall, he was pretty gung ho on doing the focal laser ablation, and it was sort of kind of a marginal situation at best whether he should consider that.
Right.
Yeah.
Yeah. I mean, I don't know. I've heard of Dr. Sperling a lot, but I don't know him. I don't know him. I don't know anyone else who's gone there. Of course, you have to pay out of pocket. It's not covered by insurance. And I mean, so he had to rob his retirement a little bit to do this.
Yeah, I mean,
anyway, interesting one.
yeah. I mean, the question really is whether he was a candidate for that focal laser ablation in the first place. That's the $64,000 question. But anyway, at this point, it's kind of moot because he.
I've come to the realization my job is not so much to dissuade people. What if they've got something in mind for treatment? I will, I'll do some research for them and I'll give them my opinions and so forth. But I certainly, if they're gung ho or moving in a certain direction, I can't talk. I'm not about to talk them out of it.
Right. I hear you. Anyone else want to comment on that situation? Okay. All right.
Well, I think it was a poor choice of therapies. I don't trust FLA, frankly.
Yeah.
Maybe for the most innocuous types of prostate cancer that may not need any kind of treatment anyway. But not for anything else, in my opinion.
Yeah, I would agree with you, and I think Peter and I at one point even chatted about that. I think if you have, 3+3 or possibly 3+4 disease with very little 4 that needs treatment, but if there's any indication that it might be more aggressive, it's dubious. And my problem is that a lot of these practitioners, Sperling included, because I've seen him do it before, say, oh, we can treat it. And, what's interesting, when exactly did he see the spot on the spine? Was that before or after? Or do we not know?
I think before. I think it showed up on a multiparametric MRI, which he did over there in Florida.
To me, he had no business doing the FLA if he saw that. That's my.
I agree.
Right. Okay. But yeah. But I don't think in this setting it's where we should go into this because it's, we're talking behind the guy's back. I mean, if he was here, maybe we could.
It's not an issue about the guy.
Yeah.
It's not an issue about the guy. For me, it's an issue about the ethics of some of these practitioners. And I don't have a problem discussing that on this call.
Right. I agree with you.
And the problem with many of these guys that are practicing these marginal focal treatments is that they have a monetary conflict. And they can't turn $20,000 away. And, if a guy sees a spot and he's willing to biopsy it, which, biopsying the spine is a very, very tricky thing to do, but fortunately he did it safely. But if you're willing to biopsy it and you find out what it is, I would want to wait on the results because otherwise you're taking 20 grand from a guy that perhaps you shouldn't be. Now, I will say you could argue that from his point of view, which is, well, let's debulk. Because now we know that a lot of doctors are debulking advanced and metastasized disease anyway.
Right.
Guys on our call that do that all the time. So it's not inconsistent. But what I do think is that it changes the whole decision-making parameter if you know that you have metastasized disease as to what you want to do first, where you want to start, how you want to debulk, all of these issues. And it bothers me with too many of these docs that they grab the money and run. So on the other hand, I think it's very positive in Sperling's favor that he saw the metastasis and he identified it. You know, he said he may have given this guy many more years of life.
Right.
So, you know, there are pros and there are cons.
Yeah.
Anyone else want to comment? Okay. Well, we've gotten through everybody, and John Appler didn't come back on, so we'll save his discussion till next week. Is there anything anybody would like to raise? Any questions before we close out tonight?
Yeah, I've got a quick question.
Please.
It's in terms of the schedule. So next Monday is the 5th Monday of the month. Next Tuesday is the 5th Tuesday of the month. Are we going to have an advance call next Tuesday, or are we going to skip next week?
No, we won't have an advance call next week. There will be a plenary on the 29th, and then we will have the next call will be on Monday the 5th, and the next Tuesday call will be on the 13th.
So we won't have an advance call next week. Is that what you're saying?
That's right.
When is the call about sleep problems?
Next Monday night, the 29th of January, the 5th Monday.
8 o'clock Eastern.
8 o'clock Eastern. And then we move into February again with the 1st and 3rd Monday and the 2nd and 4th Tuesday for our advance call.
Sounds good.
Okay, Peter. And for you, I'm assuming the 2nd and 4th Monday for your low and moderate call.
Right. 12th and 26th.
Yeah. Okay. Thanks for raising the clarification. So I will send out, Peter will send out to his list, and I'll send out to my list a notice towards the end of this week about the plenary call.
Okay. And if you speak to Rob, tell him we're thinking of him.
Yeah, I absolutely will. I think he's going to probably start Carboplatin pretty soon, pretty quickly. So, and yeah, one big piece of news that Alicia Morgans gave him and he passed on to me, and then I verified on the internet, is that Chuck Ryan is leaving UCSF and will be heading up the oncology group at the University of Minnesota in Minneapolis.
Wow, interesting.
So, and there is a press release. If you can Google it, you'll find it. There is a press release. So, one thing that means is that Stuart Bloom in Minnesota, in Minneapolis, is a very good doc, and Rob's been with him for a while. But for people that are in that area, or in the northern Midwest area, there's going to be a really good option for a GU medical oncologist, and I'm sure there will be more GU medical oncologists as he grows that department at the University of Minnesota.
Interesting.
And we wish him the best, and I'll be writing to him on behalf of all of us. He's done some some really great work, and he's worked with a lot of guys that we know at UCSF. So he'll be a loss. Okay.
And he
Go ahead.
said he and Dr. Morgans are quite a team too on their exploration of different themes.
Yeah, absolutely.
Yeah.
Absolutely, absolutely. But it's good because you know, it gives us, I mean, we certainly have good contact now with Alicia Morgans, and we'll have now good contact at the University of Minnesota in Minneapolis. And you know, we get enough people who are in that area. I mean, you know, somebody like Jay Kruckman, for example, it's another option. Jay, he's starting there in April. I don't know whether the University of Minnesota is in your network or not, but it's.
I can definitely check it out.
There you go. And be happy to give you a referral to Chuck. I mean, I know him very, very well personally. He actually lived in the same town that I lived in Northern California.
Okay.
And by the way, Chuck Ryan was the principal investigator for abiraterone for Zytiga. He's one of the developers of Zytiga. Okay. We filled another 2 hours. I'll speak to hope for you. I really encourage all of you to attend the plenary on sleep next Monday night. Send me questions. You'll see the publicity as it comes out. And if you have friends who are afflicted with any type of cancer, mention it to them, because I think if you're living with cancer, then it's going to be a very useful session for you, whatever that cancer is. Okay. Goodbye, everybody. Peter, I'm going to give you a call.
Good night.
Good night.
Good night.
Okay.
Bye.
Night.